Welcome to Navigating Uncertainty. We're starting with our next session here, Impacts of State and Federal Decisions on Healthcare in Washington State. My name is Christian Gilbreth, and I am the treasurer of our chapter. Before we get started, don't forget about your CPE at the back of the room, 1.5 credits for this session. So I would now like to introduce Zosia Stanley. So Zosia serves as a vice president and associate general counsel at Washington State Hospital Association. WSHA represents all the hospitals in Washington State and works to improve the delivery, quality, accessibility, and affordability of healthcare. Zosia provides legal counsel to WSHA and advocacy for hospitals and healthcare systems on legal, legislative, and regulatory issues. Again, I want to make a comment that your feedback is very important. Coming from our Seattle conference, Zosia's appearance here was strongly advocated, especially through our times here. We know the different types of regulatory and legal circumstances are difficult. If you saw me raise my hand, my name's Christian again. I'm from Alaska, and we work very closely with our legislators and our own WSHA of Alaska up there. So at that, again, thank you, and I'd love to welcome Zosia. Yeah.
All right, get all my things organized. Hi, everyone. It's good to see many of you again. Last time I think I spoke to HFMA was in March in Seattle, and at that point it was things are happening, who the hell knows, and we know more things now, but not necessarily with more certainty, so that's my scene setting. It's nice to see you all. As mentioned, I'm Zosia Stanley with the Hospital Association. I appreciate you all having me. I think I have 72 minutes to speak, so I would love questions as we go through. I'm happy to take questions. I may not, as I told you in Seattle, I may not know the answers, but we can ponder them together and we can think about resources. All right. Totally works. Okay. So learning objectives, and please let me know if my mic is too far or too close. It's a little bit of figuring out the magic place. We're going to talk about what is happening at the federal administrative level. We're going to talk about what's happening at the state level. We're going to talk about specifically hospitals, but I think broader healthcare implications about the kind of financial health and state of our healthcare providers in Washington State, and I think that there's ramifications for Alaska as well. Each state's a little bit different, special little laboratories of democracy, but the federal impacts are pretty substantial for each state. And then talk about some practical considerations, because I'm going to leave you with a lot of, there are big things happening. They're going to be happening for several years, barring other things happening. And there's a lot of things to prepare for and think about, and so I'll leave you with a couple of practical considerations. But just as a headline, there's a lot of things are going to be hard, are going to continue to be hard for a while. It's a little bit of a headline. So I hate to be a little bit of a black rain cloud in the lights of the casino, but I think that's where we are looking in the state and federal levels. So we'll talk about, as I mentioned, this kind of state cuts in taxes and hospitals, because although we're talking a lot about H.R. 1, and that is also known as the One Big Beautiful Bill Act, all the things that were passed on the 4th of July, the more immediate impacts are going to be at the state level, and I will talk about Washington because that's where I am an expert. I think Alaska probably will be similar in that there's some state things that are happening there. We will talk about H.R. 1 impacts, which are many. You could do many, many hours of discussion there. We'll talk about financial outlooks for hospitals and systems. The 2026 legislative session in our state is going to start in January. We'll talk a little about that. And then the practical considerations I talked about. And again, please feel free to ask questions as we go through. I really welcome them. I will listen to myself for 70 minutes, but it's not as much fun as talking with you all. All right. So, as mentioned, I'm with the Washington State Hospital Association. We represent all the hospitals in the state of Washington. There are 114 hospitals. We are a trade association, and we do a lot of advocacy for our members. We do 3 big pieces of work: advocacy, clinical excellence, and data analysis. And just in case you're curious, I think it's interesting, of our 114 hospitals, there are 53 nonprofits, 42 public hospital districts, 10 for-profit, 5 county, state, and 4 military veterans hospitals. And I like this map because it kind of gives you a feeling of like where the hospitals are in Washington State. If you are, raise your hand if you work for a hospital in Washington State. You are a member of the association. We appreciate it. On our website, you can get access to this map and other resources. We have a login information, so let me know if you need any help, but lots of resources on our website. And if you're not a member of the association and you want some resources, let me know. I'm happy to help where I can. WSHA's mission is to support the work of our hospitals, and our, well, this should be vision, not values. Vision is to be a trusted voice and indispensable resource to lead, challenge, and assist hospitals. So a little bit of work to be done. They do great work, and we try to support them. A couple of disclaimers and context. I think I said the same thing in Seattle if you were there, but I will say it again because I think it's helpful. I'm an attorney, but I'm not your attorney. If you have questions, I'm happy to talk to you about some guidance or thoughts, but I won't give you legal advice because legal advice is worth what you pay for it. You're not paying me, so don't take my legal advice. But do talk to your legal, regulatory, and compliance folks in-house. They're excellent, and we are a resource to them. They're a resource to us. I will be focusing today on the impacts and outcomes of political choices in the state and the federal government. I'm not going to talk about the political process or my opinion about the political process. I do have them, but here I want to talk about the impacts and outcomes because that is where we're going to need to be paying attention. There's lots of other noise out there, state, federal, et cetera, but we're going to talk about the impacts and outcomes. All right, so diving in. We're going to talk about state cuts and taxes. So the last time I spoke with you all in March, we were just ending the state legislative session, and I think if you were there, we talked about the fact that it was a budget year. The state was looking at a $2 billion deficit. The murmle does matter, but it was debatable what exactly the deficit was. And so to come out of session, the legislature has to have a 4-year balanced budget. We're, I think, one of the only states that requires a 4-year forecast. So to do that, the state has to look at now, near, far. And to come out of the 2025 legislative session, they did some interesting decisions when it came to cuts and taxes. Hospitals and healthcare were one of the only industries that took both cuts and additional taxes, which is an interesting place to be. And that was all before HR 1. So this was March, early April. And then HR 1 was passed July 4th. So although we had some inklings what would happen, we didn't have the details. And so we the state made decisions about all the information because we didn't have it yet. So for hospitals in 25, we saw a number of impacts. So there was a bill that capped payments for PEB and SEB, which is public employee and school employee benefit plans. Very deep cuts for urban hospital payments. Critical access hospitals were exempted. We set taxes on hospitals, systems, and providers, both B&O and sales tax. It's interesting, we haven't, our state legislature had not seen that kind of, the budget shortfall in maybe 10 years since the last Great Recession. So most of the people who are in the legislature now have never done this exercise of, if you do not have enough money for all the things you want to do you put new taxes on? Do you make cuts? Do you do arrangement? There were lots of ideas. There are lots of more ideas that they actually did pass, but these are the ones that affect healthcare. There was also direction that there would be an MCO, Medicaid managed care cut of 1%. We'll talk more about that. The direction from the legislature was MCOs cut, and what the healthcare authority did was MCOs, you cut payments to hospitals, which we do not think is a good idea, but that's where we are. And then in the issue of conflicts of discharge, the patients who get stuck in hospitals don't need to be there. The legislature cut ancillary service payments. We'd gotten that ancillary service payment for long-stay Medicaid patients bumped up, I think it was 2 years ago, and they took that away. It's not very much money, but it's an interesting message of kind of where they're deciding to make cuts. So as I mentioned, I start here because this is where the most immediate cuts to healthcare and hospitals are in Washington State. HR 1 is absolutely coming, but it's coming in 26, 27, 28, and the out years. So this is what, and I know this is a bit of an eye chart, so I apologize. You can see it here, you can see it on the screens. This is quantifying the impacts of those cuts I just talked about. So we have the PEB-SEB cuts. That's about $100 million annually to cuts to healthcare in Washington State. Doesn't impact, and I think is a critical access, doesn't impact the independent rural hospitals. So if you work for a rural hospital, this won't directly impact you, but everyone else it will. And then we have the B&O 5% surcharge. We have the B&O rate increase for providers, which is in addition to the surcharge. We have sales tax additions. On the sales tax, it's interesting. Specifically for healthcare, I will note that it applies to IT services and custom software, so EHRs, all the software you all use. It also applies to security services, so these impacts we'll be hitting. It does not apply to temporary labor for hospitals, We were the only industry that got a carve out for that temporary labor, so we are pleased with that, but it's still a pretty big impact for hospitals. As I mentioned, the 1% Medicaid MCO cut, talk a little more about that. So as I mentioned, the legislature said in their budget bill, UHCA shall cut 1% from MCOs, and the way that they decided to implement that was to say, we think that MCOs are paying excessive rates to hospitals. I do not think that anyone feels that a Medicaid rate is excessive at this point, but be that as it may. And so the healthcare authorities recently announced they're going to do two things. Thing one, and I'm looking at my notes because it just came out the other day, for behavioral health, so inpatient psychiatric rates, there will be a $9.6 million reduction in MCO capitation rates. So if you are a provider of inpatient behavioral health services, be aware that that is coming. There'll also be a $4.5 million benchmarking adjustment reduction for MCO capitation for other behavioral health services. And then the other thing HCA is doing, not in behavioral health, but in other places, is they are changing the outlier threshold for high dollar claims. So the threshold is changing from 40K to 45K. They were going to do something much more drastic, which they did a ton of advocacy with the state to say, you want to be really thoughtful about what you are doing here. You want to really think about this. This is not what the legislature directed. HR1 is coming, et cetera, et cetera. So it is less bad than it could have been. It is not good. I will also note that as a result of these changes, MCOs may be seeking to renegotiate contracts with healthcare providers and hospitals, so be aware that there may be some more contract negotiations if that's a world you live in that might be coming your way. And then as I mentioned, there's also the ancillary services cuts, which it's not that much money, but it just feels kind of mean. These are patients who are stuck in hospitals, who don't need to be there, who are there for a certain length of time, for whom they need PT, OT, some kind of service that if they were in a outpatient setting, they would be getting payment, but because they're in a hospital, the hospital can't be quote unquote double paid, so there's no reimbursement for any ancillary services. So that is complex discharges by issue, so I feel that especially strongly, but it's an interesting set of choices that people make when they have to make cuts. Let's see. So then with that background of those are the more immediate cuts that are happening, we will move on to HR1 impacts. They're substantial. I want to note that there are many, many more HR1 impacts than the ones I'm going to talk about. I'm going to talk about the ones that are Medicaid specific, but there's also pieces around non-citizens, lawfully present immigrants, health benefit exchange, the enhanced premium tax credits, which are a linchpin issue in the current federal government shutdown. There are a number of other pieces around like the WIC and SNAP programs. I'm going to talk about Medicaid because that's the piece that is the most directly impactful immediately. I will note that I don't have a lot to tell you about the government shutdown, but I talked to our federal lobbyist this morning, and here are her thoughts. One is buckle up. This is day 15. There's no movement. Everyone is very much, stuck in their positions. Everyone's bunkered down. It's a little bit of political theater at this point. I think both sides are waiting for everyone to blink. It sounds like the federal government will be paying military in the next paycheck, so that's something that apparently is coming from tariff dollars, unclear. It sounds like there's also going to be payments for WIC in the next payment round, but that may run up at the end of the month. So November is probably the time where we're going to see something happen. Oftentimes there's some kind of inflection point, whether it's air traffic control or military or something's going to happen that will press one way or the other. And as you probably have been watching, the Democrats' position is we can't agree to anything unless we address the enhanced premium tax credits on the health benefit exchanges. Eligibility is going to go away for those, and those eligibility both funding or eligibility. And so the Democrats are saying we have to deal with that, and the Republicans are saying we don't really have to deal with that. It doesn't happen to the end of the year. We have time. And the Democrats are saying yes, but the notices are going to start going out in November. The people are no longer going to get those tax credits. And so there's, it's a little bit of a game of chicken. As far as we can tell, the House the Democrats are not going to come back in the near future. The Republicans are doing some hearings, which is, kind of standard for what the feds are doing these days. The House did pass a continuing resolution. The Senate did not, because the Senate needs some Democrats to come over and agree with the Republicans. But the House's continuing resolution expires in early November, so yeah, unless they figure it out pretty quickly, everyone's going to have to come back and pass new things. So that's my shutdown update. It's a lot of nothing at this point, but it's a lot of watching, which is interesting. Okay, So, HR1. So this is the timeline of HR1 impacts. Come back to my page. And I mentioned what's not on this timeline, but I will just note again, is in October 2026, Medicaid eligibility for a lot of lawfully present non-citizen immigrants ends. So these are folks who have legal status in the U.S. and have been deemed eligible to be here and have been eligible for tax credits on the exchange, and they'll no longer be eligible. There's also going to be federal funding reductions for emergency Medicaid services. And then December 31st, 2026, ACA premium tax credits end also for lawfully present immigrants. So those are kind of the nearest term impacts. And then we get into January 2026. Well, I guess December's after that, but anyway. So January 2026, the hospital safety net assessment programs, or the directed payment programs, are going to start ratcheting down. I'll talk a little more about that in a moment. But just to note that is, in our state, that is a mechanism used to bump up Medicaid rates for hospital services up to near commercial rate. And that really impacts the health of hospitals because we serve a lot of Medicaid patients. There hasn't been a Medicaid rate increase in Washington State in many, many, many years. And without this directed payment program, the rates are real crummy, is my technical legal financial term. I will note, and we'll talk more about this, that so the rural fund distribution is in September. We'll talk a little bit more about that. And then in January 2027 is when a lot of the big things happen. So that's when, and this is from Medicaid, so work requirements will start phasing in, limits on retroactivity of coverage, and also re-verification. And I will note that for each of these three changes, the major impact will be on the Medicaid expansion population. So there's traditional Medicaid and there's expansion Medicaid after the ACA. And we'll talk a little bit more about the why of this, but most of these changes will hit the Medicaid population who are expansion the most firmly. So that is both the Medicaid population who is expansion and also states who have chosen to expand Medicaid. Washington State's expanded Medicaid as much as we can, lots of states have, but because the federal government pays more match for expansion populations, they have chosen to put more, I think, burden and barrier on Medicaid eligibility for those expansion populations. And then we get another set of cuts to the directed payment program in 2028. And also in 2028, there'll be a new requirement for Medicaid entities for states to require co-payments for Medicaid. Right now, Washington doesn't do co-payments for Medicaid populations. And we'll talk, there's an interesting interplay with our state charity care law, and I don't know that you can do both those things, comply with charity care law and also collect co-payments from Medicaid patients. But that level of detail sometimes escapes everyone. Let's see. I wanted to note a couple more things. I think that the piece to also be aware of on the retroactivity. So for the expansion, so currently you get 3 months of retroactivity. The change will be for the traditional Medicaid population, it narrows to 2 months of retroactive coverage. For expansion, it's 1 month. That's a really quick turnaround. If you have somebody in your hospital or otherwise a patient who could apply for Medicaid, you give them care, they apply for Medicaid, that's a real quick turnaround to get 30 days such that they can, their coverage will pay for the care that you provided them. So just briefly to do a little bit deeper dive into the directed payment program, one, because the directed payment program is delightfully complex, and I like this graphic because it's a nice way of kind of conceptualizing it. So that the way that the program currently works is that hospitals tax themselves in Washington State, and that there's some state dollars, draws down federal match, it gets put back to the MCOs, and the MCOs pay it to hospitals in the form of Medicaid payments for patients who are served by those hospitals. So currently hospitals contribute about $452 million of funding in a biennium, meaning a 2-year cycle, to state funds. The state and then we get federal match. The state does take some of those funds for other programs, but the majority are that Medicaid bump. And the change in HR1 is that over time they're going to ratchet down the ability to pay anything above a Medicare rate. Medicare is better than Medicaid, but it's not a good payment. It's definitely not near cost. And over the next 10 years, the reductions are going to basically wipe out any bump of savings in this program. We in Washington did a ton of work in 23 and previously to establish this SNAP program. We call it SNAP, not federal SNAP, state SNAP. So we don't call it SNAP anymore, but directed payment program. And this is going to be a big impact, as I mentioned, to the ability to serve Medicaid patients in Washington State by hospitals. This is my other points that I just made that I forgot I had this extra slide. So these points around like what's going to happen in the end is a big wipeout of the program. And part of this is, I think, intentional from the federal government looking to decrease the amount of federal dollars that need to be spent in these programs. There's also an interesting perspective. There's some kind of money laundering program going on, and I gotta say, if it's money laundering, I would hope we'd have more money, more dollars. It's not. It's a pass-through program. There's very clearly delineated state and federal law, but seeing all that, having to have that slide of how it works and all that detail is much less attractive than just saying it's money laundering, stop doing it. So the details do matter, and unfortunately, in our rhetoric, we do headlines. Headlines are much more attractive than having to do. This is a deep dive into how this works. So we talked about, I mentioned the Rural Health Fund, Rural Hospital Fund. We'd like to be a rural hospital fund. So part of the process for getting HR1 passed was feeling they had to do something to maintain rural healthcare, because people kept saying, hey guys, if you cut Medicaid payments to a lot of hospitals, they're rural hospitals whose vast majority of their payers are Medicare and Medicaid. And maybe that will be challenging for those hospitals to remain, and even if you don't live in a rural area, you can maybe appreciate that you would like to have a local hospital or somebody to screen and stabilize and in case you have an emergency and transport you to the next hospital, or someplace for the urban hospitals to send patients back to in their communities to do recovery and other things. And so I think very much towards the end of the process, right before July 4th, they added this rural hospital fund, rural healthcare fund. So Congress funded the program at $50 billion, which is a lot of money. Like even in federal government terms, that's a lot of money. But it's $50 billion over 10 years, with $10 billion of funding available each fiscal year beginning in 26. Half of that money, so $25 billion, will be distributed equally amongst the approved states. So just because each state will apply, I'm sure every state will apply for the money, but not every state necessarily will be approved. It is a little bit unclear what the standards will be. The applications are out now. States have like 55 days to apply. And then the other half of the money will be allocated at the discretion of the CMS administrator, who is Dr. Oz, based on a variety of factors, including rural populations and other things that are a little bit unclear. I looked at the website about the standards, and I don't know that I could figure out what a successful application would look like. So in Washington State, our healthcare authority has been working on an application. Before the applications opened, they solicited feedback from across the state for how should we spend this money. And I will say, although I think rhetorically there's a lot of conversation about maintaining and supporting rural hospitals, just out of curiosity, who here works at a rural hospital? Anybody? Okay. So the point was rural hospitals, but I think there's lots of other people who say like, well, I'm in rural healthcare, like I should be, I could use some money. I'd like to do workforce development. I'd like to do EHR support. I'm a federally qualified health center. Like there's a ton of other entities who would be very interested and very grateful for these dollars. So in the applications, the healthcare authority was noting they wanted to focus on potentially asking for dollars for long-term care, workforce, so like loan repayment, training, recruitment, et cetera, telehealth, telespecialty care, care coordination, maternity care. Unsurprisingly, we have some, I think, developing OB deserts in Washington State, so they'd like to focus on that. So they gathered that information. They're currently working on their application. There's I think it's 5 different state agencies who are all working on applications. They're going to bring it together and submit it to the federal government. We're guessing Washington State will probably get maybe $90 million a year. And that's still real money, but probably 10% will go to the state for administrative costs, 10% will go to the tribes. And so we're guessing maybe 40 to 50% of that money might go to actual rural healthcare providers, so hospitals and others. So when you get to that point, that is not a ton of money, especially when you think about, we're going to talk about, there will be impacts for hospitals in Washington State around charity care increases. Because as people fall off Medicaid rolls, they are inherently eligible for charity care at hospitals, because Medicaid is a 138 FPL standard. Charity care in Washington State is free up to 200% FPL, reduced 3 to 400%. So we'll talk about the fact that we expect a number of people to fall off the Medicaid rolls, and that will mean more charity care at hospitals. Charity care in Washington State is not funded by anyone but the hospital itself. So we are doing a lot of discussions with the state to say, we see this wave of people who are going to lose insurance, and we want them to have emergency care. That's the point of charity care, but this is not going to be viable in any way, shape, or form. The last thing I'll say on the Rural Hospital Fund, my federal person was saying, there are 1,000 blooming flowers of ideas. So there's lots of ideas for how this money should be spent. I think it'll be different in every state. The other thing is that once you make an application and the feds approve it, you can't change. So you're locked in for a number of years to do whatever you thought was the right thing to do. Okay. So now we get into the Medicaid implications. And please ask questions as I go forward. I'm happy to answer your questions. So work requirements are new. There's one state that I'm aware of that has implemented work requirements for Medicaid populations. That's Georgia. Georgia's a bit of a cautionary tale. It was a ton of money to implement, and it's been really hard to maintain to figure out how to make that process work. So currently in Medicaid program, Washington State and most states, no work requirements. It's not about earning the privilege of the Medicaid coverage, right? It is because you qualify based on your family size, your income, your disability, your other situations. Work requirements start January 2027. They will require if you are an adult over the age of, I think it's over the age of 18, and again, an expansion adult. So not traditional Medicaid, but expansion. And unless you have kids under the age of 14, so it's 18 to, I think it caps out at a certain age at the upper end. Unless you have a kid who is 13 or younger, you have to have 80 hours a month of qualifying community engagement, which is a term that they use as work requirements. And that has to be work, school, or community engagement. There are waivers available for states to waive this program or delay this program. It seems very unlikely to anyone I've talked to that many states will get waivers, and probably not Washington State. We are on the west coast of liberalism, which is not always aligned with the federal government's administrative interests, and so there's maybe not a meeting of the minds in a lot of things, and so it's unclear that a waiver would be feasible. Nationally, there's an estimate that something like 5 million people may fall off Medicaid from time to time because of the work requirements, and this is not because it's not that the person is not eligible, doesn't need the coverage, it's that they haven't done the documentation or proof that they have met the work requirements within a certain time period. There are exceptions to the work requirements. It doesn't apply to kids in foster care, up to 26, Indian Health Service recipients, caregivers, disabled vets, medically fragile individuals, people who have already met requirements under like TANF programs, those participating in qualifying substance use disorder programs, incarcerated or recently released from incarceration in the last 3 months, pregnant, etc. Thing is, though, that a lot of these are really unclear exactly what the detail will be here. And things like, if you have been released from incarceration in the last 3 months, it probably is very challenging to find any kind of work or community engagement. Also, if you have had a severe substance use disorder or behavioral health condition, it is very challenging for you to maybe then find work while you're still recovering. So I think there's a lot of questions in our minds around what will this look like. And we'll talk a little bit about the fact that I think if you work for a healthcare provider, clinic, FQHC, hospital, etc., there's an opportunity. I think you will be asked to help people apply for exemptions or to do paperwork to kind of support their request for exemptions. So a lot of detail in this program is not yet clear, but it is coming, and I think there'll be a lot of preparation by the state as we go forward. There's also the question in our minds about, like, does the state have the infrastructure to do this tracking? I think the answer is probably no, right? We have Provider One at this point. We have a couple other state Medicaid technology pieces that work okay, but don't have a lot of nimbleness to them. And I don't know if you've ever seen the state try to build a technology platform. It takes them a little time and a lot of money. So it'd be challenging to see kind of how they stand this up. The other thing about work requirements is a lot of folks, I think, don't know that it's going to come to them, right? I think there are people who don't know that Apple Health is Medicaid in Washington State, or that Sooner Health is Medicaid, or whatever. Each state kind of names their Medicaid program a different name, and so lots of people don't directly correlate, I'm a Medicaid recipient, this will apply to me. A lot of the changes in the Medicaid requirements were really framed as kind of waste, fraud, and abuse issues. And I'm certain that there's waste, fraud, and abuse in the system, but a lot of these things aren't directly connected to you're a bad actor, thus we're going to do these things. It's blanket policies that a lot of people are going to be impacted by. And I think there's going to be little understanding about the fact that, so work requirements, but also re-verification, moving to every 6 months, that's a lot of additional paperwork people are going to have to pay attention to. And I work in healthcare, and I don't understand my insurance things, and I don't think a lot of people do. And so getting more of those insurance things and getting more notes from the state and more information is, I think, going to be a real burden and noise in people's lives, especially if they're at a point where they are recovering from healthcare or dealing with healthcare issues. This kind of needing to reapply and verify is going to be a challenge. So then we also have limits on retroactivity coverage, and as I mentioned, the real concern that we see is we will see patients who come into hospitals who have had something really catastrophic happen to them, and they have very, very expensive health care that they need very quickly when they come into the hospital. And they stay with the hospital for a little while, and they get better, and then they may discharge to long-term care, to a nursing home, adult family home, assisted living, home health, et cetera. And at that point, there's a little bit more stability, and they start applying for Medicaid and getting their financial information together, or if they don't have capacity, durable power of attorney agent will come in, or a guardian is appointed, and then they can do the Medicaid application process. But the Medicaid application process is, even if you were really quick and you had all your documentation, it doesn't move super fast. And we already see the state, for the Medicaid financial eligibility staff, they have cut their staff, and their staff and I'm sure that they're working as hard as they can, but they take a long time. Even if you got your stuff in early, it takes a while for that to make an impact. So the concern we have here is that for the expansion population, it's a 1-month retroactivity. That means you have 1 month to apply, get all the paperwork going, be found financially eligible for long-term care, or functionally eligible. There's a ton of state process that has to happen, even beyond the paperwork and the process pieces. And this is going to potentially have a big impact on Medicaid. As I mentioned, I keep saying Medicaid payments are not great, but they are better than $0. And if you get $0 for some of this care, it's going to be a real challenge. So we'll talk about this later, but if you are, again, working in a healthcare arena, you may think about how can you help patients with, do you have a navigator on site? Can you connect them to the health benefit exchange to get on the platform? Is there a way that you can support patients in kind of speeding up that process? And this is another eye chart. Apologies, it's a little bit hard to see, but I think this is interesting. So this is the Kaiser Family Foundation. Well, I guess they're KFF now. They've rebranded. But this is, again, to that point about expansion versus traditional Medicaid populations. So most of the impact here, and I think this is $911 billion of savings projected from HR1 in the Medicaid world. Most of the impact is in this blue side, which is the expansion side. There's a hit to the traditional Medicaid population as well, but most of it's on that expansion side. And you are probably all aware, right? So I mentioned this briefly earlier. Medicaid is a state federal matching program where the state puts up money and the feds put up money. For the expansion population, it's 10% state, 90% federal government. So you can see why the feds would say, well, I would actually rather not spend that amount of money for an expansion population. I might want either people to move back into traditional Medicaid if they can, or make it more challenging for people to maintain if they don't meet the standards we think are appropriate for them around work requirements, eligibility, et cetera. That means that the HR1 penalties are much more deeply felt by the expansion states. There are 40 states plus DC have expanded Medicaid after the ACA. Washington State did it really early on, post-ACA. We had a Coverage is Here campaign, and we've done a lot of work to say there is eligibility, there is coverage. Please come in and get health care insurance, because it applies not only to your emergency care, but your primary care and all the other things that we provide. And Washington State has a very rich Medicaid benefit. So the challenge will be that these states that have done this work to say, come in, get qualified, get eligible, get covered, are going to have to do, I think, a substantial amount of work to keep people in that coverage, and we will see people kind of come out or churn back and forth, or have anxiety about what can I keep my coverage? Am I worried about going to the doctor? So I think those are some real challenges that we have ahead of us. I think that's another thing I was going to say. The other thing I think is just to note, we're talking a lot about Medicaid, but will there be an impact on Medicare eligibility? If you're a dually eligible person, if you lose your Medicaid side, you will also lose your Medicare side most likely. So it expands beyond just the Medicaid population, the impacts of HR1. And to the point I was making earlier, I just think this is a helpful population. We are in the dark coast where we will lose, I think, a lot of Medicaid dollars. And I'll talk about this a little bit later as well, but federal Medicaid dollars are used by states for the Medicaid program. If you lose federal dollars, you either have to stop providing that service or find other dollars. Washington State, as I mentioned, had $2 billion shortfall last year. It's not getting any better looking forward, so it is not as if there's a bucket of money to backfill these cuts from the federal government. So that is a little black rain cloud of worry about H.R. 1. Happy to answer any questions now or as we go forward. I will say that a lot of the detail will reveal itself as we go forward, as the agency, federal agency does rulemaking, as CMS does the rural fund allocation, as the state figures out how do we operationalize a number of these provisions. I think I didn't mention, but one of the federal H.R. 1 requirements was a pause of a bunch of kind of simplification and streamlining of Medicaid application processes, things as simple as allowing the state to send a Medicaid recipient, hey, you need to re-enroll or renew your eligibility. Here's a pre-populated form of everything you gave us previously. Is this still correct? Versus sending someone an entirely new form and saying, please go find all the things you told us a year ago. We had been starting to do that, the easy form, and we can't do that anymore because the federal government won't allow those kind of processes. So I think the other thing that the state is thinking about is, as I mentioned, there's going to be, I think, more concern for non-citizens who are lawfully present or not, but previously for the lawfully present could get some Medicaid coverage or some exchange coverage, and probably are not eligible anymore, and then also I think have a concern about seeking out healthcare at all, given the concern about ICE and other people being present in healthcare facilities. So just more worry to add. Okay, and more uncertainty and worry. Worry challenge problem. I mentioned these briefly because they're all kind of healthcare related or adjacent, and I'll add visas to this list because that's a newer issue. So HIPAA, you are probably all aware, so when the Dobbs decision was passed in, time's a flat circle. When was Dobbs, 2023? Overturned Roe v. Wade. Roe v. Wade had been the law of the land since the 70s and said there was a constitutional right to abortion. Dobbs overturned that and then allowed each state, as a laboratory of democracy, to make their own laws about abortion access. So there's been a big split among the states, the kind of liberal conservative. There's a protective approach, and then there's a kind of more permissive approach. And as part of the kind of overturning of Roe and the imposition of Dobbs and the changes in state laws, the federal government under the previous administration had passed rules to protect the use or disclosure of reproductive health service data. And those rules were supposed to go into effect, I think it was the end of this year, October, November, around now. And the new federal administration has overturned those rules. So there's no longer heightened protections for those kind of data. And we have seen states that are more restrict around abortion access try to reach into states that are more permissive in abortion access to get data about their patients who are traveling across state lines. So if you're a healthcare provider, this is an area of interest, not only because of the patient protections, but there are states in the federal government even who are interested in which of the providers are providing this type of care to patients. So I know in the state folks are thinking about, is there a way to protect provider information when it comes to sensitive services? I don't know what the answer is there, but it's an area of, I think, of growing concern. Under EMTALA, similarly, post-Dobbs, overturned Roe v. Wade, there were states that said, so EMTALA, right, is the Emergency Medical and Treatment, I was saying Act of Labor, Treatment Act of the 80s, right? Late 70s, early 80s. Been in place for a very, very long time. And EMTALA says if you are a hospital with the emergency department, you must screen, if a person comes to the ED, you must screen, stabilize, and treat or transfer that patient. For many years, there's been most states and the federal government have taken the position that screening and the stabilizing treatment for somebody having a miscarriage could be an abortion, depending on kind of that patient's needs. There are states that have said we don't think that is appropriate healthcare treatment. There are states that we do think that's appropriate healthcare treatment. And again, the prior federal administration passed guidance that said, yeah, absolutely. Miscarriage management is part of treatment under EMTALA. You are required, if you are a hospital in that state, no matter what your state laws are, you're required to be an EMTALA. EMTALA preempts state law. There have been a number of lawsuits. Unsurprisingly, I think Texas and Idaho have played a part in that. And the feds recently rescinded that guidance and said, no, we don't actually think that that is an appropriate interpretation of EMTALA. In Washington state, we already had a miscarriage management law that says that regardless of your hospital type, Catholic, religious, secular, et cetera, if somebody comes to the hospital and needs miscarriage management appropriate treatment, that is required to be provided. So we already have a law that protects that situation. But in 2022, we codified an EMTALA law, and we just this last year recodified EMTALA. I don't think we need to do that because EMTALA has not actually changed, but we do have kind of double protection in Washington state to be really clear that we really mean that EMTALA will cover those types of services. Birthright citizenship has been assumed to have been a constitutionally protected right in the US for many, many years. If you were born here, you're a citizen. Trump, in an executive order pretty early on in his administration, said, nope, that is not the case. And there's been a number of lawsuits, including Washington State's Attorney General versus the Trump administration. WSHA and the Medical Association actually filed an amicus brief in that case, saying, hey, if we have to verify someone's citizenship, either as a patient or at birth, et cetera, or if there's variation, if somebody says, I was born in Washington and I am a citizen of the US versus I was born in Idaho and I'm not a citizen of the US. If I'm an Idaho non-citizen and I come into Washington, am I now a citizen? I do not know the answer, but it's an interesting question. Right now, the EO has been stayed so that there's no change in birthright citizenship, and I think there'll be a number of lawsuits working their way through the courts, actually on all these things. I think most things I'm talking about, there's a lawsuit somewhere that's gonna work its way through the courts. Because lawyers have a lot of job security. The other one to note is gender affirming care. So there have been EOs around gender affirming care and whether that is appropriate care for children, minors under the age of 18. In Washington state, we do have laws around insurance and provider requirements that do require the provision of appropriate care, which can be gender affirming care. The feds have said that they're going to stop payments to organizations that provide gender affirming care. There's a lawsuit, of course, about this one. Washington v. Trump, et cetera. The federal funds are still flowing, but there are, I think, a lot of concerns about, even if a state were to codify a law that says, no, you as a provider must provide all of necessary care, that includes gender affirming care. If the feds come in and say, that's great, but I'm not only not gonna pay you for that care if it's a Medicare or Medicaid patient, Medicaid if it's a kid, but also there's proposed regulations to amend the conditions of participation under Medicare, under CMS, which are a big deal for a hospital. If you violate the conditions of participation, you can be fined. You can have an order that says you can't treat Medicaid patients. You can have really unpleasant interactions with the federal government, which nobody wants. Once the feds come into your facility, they can look at all the things. And also, you could potentially be excluded from providing Medicare or Medicaid services and receiving payment for those populations if in the end they find that you violated the COPs. Those are not in place right now. They're not even draft. They have been announced that they're going to be drafted soon and published. So we're keeping an eye on that because that could be a very, very bad fact for a lot of healthcare providers. And in fact, I think there's a tension at this point in Washington and some other more liberal states around populations saying, I live in a state that's protective of my health care. I should be able to access these services. And hospitals and anybody else who receives Medicare, Medicaid, federal funding saying, I would like to continue to provide these to you, and I am worried that if I do this now, even if there's not a COP change right now, it could be retroactive. They're usually not, but they could be. And there are some other really negative ramifications that could come to me if I continue to provide this service. So we've seen hospitals wax and wane in their ability and willingness to provide gender affirming care, and it's really challenging for the patient population, but it's also really challenging for the provider facility to say, what level of risk am I able and willing to engage in? I will say that there are some more private facilities that don't accept federal funds that are able to provide those services, but I think there's going to be an ongoing source of tension about what type of services a CMS covered entity can provide. Another one I mentioned is immigration. So previously ICE had been subject to a direction and guidance around kind of areas that they were not going to do enforcement actions in. So courts, schools, hospitals. That had been in place for a while. That has been newly rescinded, well, not newly, in the last year, rescinded by the federal government. And actually, in the prior Trump administration, there was indication they were going to do that. And Washington State passed the Keep Washington Working Act that limits cooperation with federal enforcement efforts. And so if you work for a public hospital district, you're required under state law to have a policy submitted to the state that says, we will not cooperate unnecessarily or expansively with federal ICE administration, federal enforcement. So that was passed in the last Trump administration. Now we have the current administration who has very clearly said we're not saying that ICE won't go anywhere that we feel is appropriate for them to be. The feds have also threatened to restrict healthcare funding for any state programs that cover undocumented immigrants. In Washington State, we have a couple of those programs. We don't use federal dollars for them, but we do provide kind of Medicaid lookalike programs for undocumented individuals. And although there are no federal dollars being used, the feds have indicated that they feel that that is an inappropriate use of funds that they will come after. So I don't know what will happen there. I think in Washington State we have dedicated funding to coverage. There are concerns about the immigration enforcement activities. I'm not aware of any immigration enforcement activities in Washington State at a healthcare facility, but it's happened in California. There have been a couple other places where it has occurred. So I think there's more to come there. If you work for a hospital in Washington State, we do have guidance that we put out around kind of things that your hospital should be thinking about policy, procedure, and training-wise when it comes to if federal immigration enforcement were to come to the hospital and seek entrance. They have limitations as to public versus private parts of the facility they can enter. There's also a difference between an ICE, I can't remember what they call them, but basically an ICE warrant versus a judicial warrant. So things of that sort, I think hospitals will need to be paying attention to as we move forward. Public health data, I have a tiny bit of good news. The federal government had removed a lot of kind of publicly available data on public websites, health data around vaccines, LGBTQ population treatment, AIDS, HIV, opioid use, SUD. They took all of that down, and there was a number of lawsuits, including one from Washington State that the Medical Association was a plaintiff in, that said, hey, you can't just remove scads of public data that healthcare providers rely on to understand how to treat their patients, and you didn't do it appropriately. You didn't follow the right administrative procedures. So a lawsuit was filed beginning of this year, late last year, and just in the last couple of weeks, they have settled that lawsuit with the federal government. The federal government has agreed to reinstate most of that data. So a little bit of good news, at least we'll have that kind of publicly available data back. Not all of it, and I don't know that will stay, because if they followed the right procedure, maybe they could remove it, but a little bit of good news. Tariffs continue to be an interesting question about kind of when tariffs go into effect, what the impact of the tariffs will be, which countries they will be impactful for. But obviously, as we learned during COVID, a ton of our healthcare resources come from not the US. We don't manufacture a ton of things here. And so if we have tariffs that are going to impact kind of medical supplies and drugs, that is a potentially substantial impact for healthcare providers. But the tariff piece keeps kind of waxing and waning, so I don't know what the tariffs are. So much as there are tariffs, there will be tariffs, there may be tariffs. Now near far, I'm not really sure. And then we talked about, we talked about the other pieces. Oh, I wanted to add visas, because that is the new thing that happened more recently that I did not add to my slides because it wasn't a big deal when I made these slides last week. All right, so HB1 visas, which are often used by healthcare providers to bring in folks to work, there's going to be a new $100,000 fee for new applicants. There are some exemptions. You can get exemptions from the Department of Homeland Security, which is an interesting department to do that work. They can give exemptions if it is in the interest of national security, but it's very unclear about what that means exactly, whether it's in the interest of national security that we have healthcare providers, so people who have healthcare licenses can come in, or if it's like Zosia, I'm not a doctor, but Dr. Zosia Stanley is exceptionally important. She individually could get an exemption. It's unclear kind of how that process will work. The other thing to note is that HB1 visas used to be a lottery system. It was luck of the draw a little bit about whether you would get the HB1 visa. We're now changing to, my federal person said, it's a little bit like the Hunger Games, but maybe reversed, in that instead of having a lottery system, you get more points if you have if it's a higher dollar reimbursed position you're going to work for. So potentially if you're working for Microsoft or tech companies that pay pretty high dollars, you may have a better chance of getting a visa than if you worked at anywhere else, including kind of entry-level healthcare positions that could eventually, grow into a higher compensating position, but don't necessarily start that way. So it may be that there'll be a different ability to access those visas. The other one is the J1 program, which I will say I know very little about, but I think that some rural hospitals do use it. And the change there will be that right now there's a duration of status where the visa is kind of good for as long as you need it to do your training or your position. And the change will be that, I don't think I can't remember if it's impacted now or it's coming. The change will be it's a 4-year visa, and you reapply every year thereafter. So I think some uncertainty if you are relying on immigrants who need visas, what that will look like in the future. All right, that was a delightful quick review of lots of problems. Any questions on these pieces? Okay. All right, so we have now wandered through all the federal things. Well, not all, but many of the federal things. So we've talked about what the state did in 25. We've talked about some of the impending implications of HR 1. Let's talk about the financial health of hospitals and health systems. This is going to continue the "is this not great news" theme. So the piece that we keep talking about is the fact that both the state and the federal government have impacts for healthcare. No matter who is making cuts, they are cuts and they are felt by patients seeking access, providers providing care, and impact the sustainability of our healthcare system. And I will say, I mention this because sometimes I think both sides can say, yes, but it's those guys did that thing to you. Not I didn't do that thing to you, those guys did that thing to you. We have more liberal Democratic folks who will say, well, we just want to be really mad at the Republicans for the things that they did. And it's helpful to say they did some things that are very impactful, and also you, the state legislature, which is democratically controlled, have also done some things that are really impactful. So let's have a holistic look at what all the impacts will be. So for hospitals in Washington State, and I think I'm not an expert in all other parts of healthcare, but I don't know that there's a ton of really healthy healthcare providers in Washington State. I know behavioral health providers, it's really challenging to do that. FQHCs have some real challenges, even though they have a different federal funding, but we'll talk about hospitals specifically. So coming out of COVID, going into COVID, most hospitals were okay-ish, in a healthy-ish margin. I use ish I'm not a financial person, so the ish is like financial things, healthy-ish. But during COVID, we actually, we saw a substantial impact on hospitals' bottom line. We didn't have any hospitals that closed at that point. Most of them dug very deeply into their reserves. And they've come out on the other side and they're okay, but they don't have the reserves that they used to have, and there's a brittleness to the system that means that there's not a lot of ability to bear more weight before there will be some breakage. And I think there's a perception that hospitals and healthcare systems have a ton of money. If they have reserves, they should be using that money. That they have investments, that money, should be used in other ways. And we, at a very basic level, right, we've decided that healthcare is a business in the U.S. It's not a right, it's not a utility. And we need these margins and these reserves to be healthy, financially healthy entities. So it's something we talk about with the legislature that it's not you see one hospital, you see one hospital, but most of them are not financially great. Okay, so I think this is a fascinating scatter chart. So this is 2024 operating margins. So the solid line is where a healthy operating margin would be. The dotted line is the state median. The bigger bubbles are health systems. Little guys are the blue guys are the rurals. You can see that the majority of our hospitals are not in a healthy operating margin, and this is before the 2025 state cuts or the impacts of HR 1. So it's helpful to just be aware that hospitals were in recovery mode coming out of COVID. They have not recovered, and they're going to be hit by these additional pieces going forward. Yeah. The other things that's helpful for people to understand is that there are a number of things that lead to the cost of healthcare, because healthcare is banana pants expensive. It is. But a lot of the things that are the kind of drivers of that are things that are not necessarily controlled by the healthcare entities. So the cost of staff, labor, supplies, pharma, all of those things has really been rising over the last few years. We also see, as I mentioned, charity care continues to rise. We expanded charity care a couple years ago, 2022. We expanded charity care eligibility. In 23, hospitals provided $473 million of charity care. That has gone up substantially over the last couple of years, and we expect it to continue to go up. And I'll talk a little in a moment about I think, some real concerns about charity care interplay with HR 1. And then, I mentioned reserves and days cash on hand. You guys are all aware of this, right? But reserves matter because you need them for unforeseen circumstances, like, say, a global pandemic that lasts for a while, natural disasters, cyber attacks, which we've unfortunately seen more of, and then planning for the future, right? If you don't have reserves, you can't plan for new services and upgrades and things like that. So we have been talking to legislators who are very expert in their areas, but are not healthcare financial people, so it's helpful for them to understand what this means for hospitals and healthcare. We do see the impacts already of kind of COVID, tough reimbursement situations, looming 2025 cuts. These are not from HR 1 necessarily, but we do see the beginnings of hospitals starting to cut services or staff. We have a number of service line cuts that we have seen. We are seeing more, not reflected on this slide. I know Children's Hospital in Seattle has announced some layoffs. Legacy, which is in both Washington and Oregon, has announced some cuts. We expect this to just continue to, unfortunately, to accumulate. So this is just another way of kind of tying, right, the state, the federal pieces together, and then also noting the regulatory issues. So even beyond what the state and the feds are choosing to do, we have some wild regulatory decisions that our state has made, our agencies have made, things around hospital staffing or charity care, certificate of need, that don't have to be operated the way that they are operated, but in the way the state chooses to go about them, means that it is harder to be a hospital or a healthcare provider in Washington state. So we will continue to talk about the fact that this is a real challenge. Our partner at the Association of Washington Businesses is doing a study on regulatory impact of businesses across the industries in the Washington state. And they did some interesting data analysis. I don't know what their data was, but I think it's fascinating. Their data showed that hospitals in Washington state have 367% more regulations than other states across the US. So if you feel very regulated, you are correct. You are very regulated. So WSHA is doing some advocacy to say, I appreciate you state can't immediately change HR 1 impacts, but you could change your regulatory approach in some areas. So we looked at the top box earlier, the blue box. This is the box with the red is the addition of the HR 1 cuts, and you can see this is real money. As we look at the out years, when all these things, assuming nothing changes, and I hope that's a bad assumption, we are looking at some real substantial cuts in the out years going forward. We're also projecting, who knows if this is right or not, but this is where we are projecting at this point, probably 37 to 40% increase each year in charity care as we go forward. So that's on top of a lot of these cuts. All right, so with that, we'll go to Washington State and our legislative session. It is October the 15th of October today. The legislative session starts the second Monday in January, so it starts January 12th. So we're in the deep in the preparation mode for legislative session. In Washington State, our legislature meets every year. They meet for even years and odd years. Some states have, I think Montana only meets once every other year, every 2 years. Idaho meets different times, but in Washington State, we meet annually. We have a pretty solidly democratically controlled House and Senate. We also have a Democratic governor, and most of our elected officials are Democratic in Washington State. It is interesting, though, when we look at kind of the juxtaposition of Washington and the federal government. So we have a lot of new leaders on both sides. But in Washington, we swing Democratic, federal government swings Republican. In Washington State, we are willing to do a lot of tax increases. Federal government is looking at tax cuts. In Washington State, we'd like to expand service eligibility and create new programs. The federal government would like to contract those things. In Washington State, we'd like to really be supportive and care for kind of a collective care approach. The federal government would be much more, I think, interested in individuals being responsible for their own personal responsibility. In Washington, we'd like to increase access to many services. The federal government would like to restrict this. So it is interesting because although they are very different, the two sides come together at the other side of the circle and they result in cuts to healthcare. So just something to keep in mind that even though we are in a state that is differently oriented than the federal government, we see similar impacts to other states. So the other thing to be aware of is that the state is still facing some really substantial budget shortfalls. So, let's see. I think the last forecast was again $2-point-something billion, and that's on top of the major shortfall that we had in 25. This is only going to get worse because the revenue forecasts are going down. Demands for social services, health care services, education, publicly funded programs are up. And the bow wave of a lot of expansion of programs that the state has done in the last couple of years is coming and hitting in these now years. And so we continue to see really bad news as we see less revenue being taken in and more money being expended by the state. So with that in mind, the legislature will come back to Olympia in January the 12th. They will work for 60 days. They will finish on March the 13th. They could go longer if they wanted to. The government can call them back. But I understand that one of the legislative buildings is going to be closed for renovation, so they have a lot of incentive not to be there. So I think they're going to be done in 60 days. They have policy work, budget work. They have to react or respond. I hope they respond versus react to HR 1 implications. They also have to deal with state budget. As I mentioned, they have to do a 4-year outlook, which means that they have to figure out, they have to forecast for themselves, what does 4 years in the future look like for Washington State with HR 1 maybe holding steady, maybe being changed? Do the enhanced premium tax credits come back? Do we have to figure out some kind of safety net system for patients who fall off their current current coverage, whether on the exchange or Medicaid? How do we do that? What would that look like? And these are really big questions, and these 60 days is not a lot of time to make all those decisions. So it's going to be a very interesting 60 days. I say that every year, but it always gets more interesting. All right, so for WSHA, we have a couple themes for the session that we are thinking about. The first is please do not do any more harm to hospitals. I will say we have been, we say this is a standard line of ours, that we would like to have healthy healthcare providers and facilities across the state so we can keep our populations healthy. And in past years, legislators go like, yeah, I know. And this year, we've had legislators practically say, I am concerned about the health of hospitals and healthcare in Washington State, which is, I think, a change, and I think a terrible place to, it's bad that we had to do all these things had to happen to get to this place, but I do appreciate there are legislators and elected officials and agencies who are saying, I see some bad things coming for healthcare. And so we'd like there to be no additional taxes. We'll advocate in both levels. I don't know how successful it will be, but I think it's a good place to start. We would like there to be fewer regulations. That would be excellent. We talked about that. We would like to mitigate some of the impacts of the B&O and sales tax that were passed in '25. Protect programs that are important for patient access, so as we can, keeping people on Medicaid rolls, keeping people in coverage where we can. We do have a package of bills around payer practices, so things like prior authorization, timely payment, payer administrative changes. I'm happy to talk more about those if anyone is interested, but we will be big fans of those bills as we move forward. And then if you're a rural hospital, we are going to support a bill, I think in the upcoming session, that addresses EMS transport. This is getting deep into the legislative session, but I just think it's interesting. So EMS transport issue is that if we have an intra-facility transport, if we can use air ambulance, we're good. But if we don't have air ambulance for some reason, there's a requirement that the people in the ambulance have certain credentials that are not available in rural areas. So you have hospitals who are saying, I need to send this person to the next level of care, maybe to Spokane. And the EMS says, I don't have the staff for that. And the hospital says, well, I guess I will send my nurse along with you even though they don't have the right credential, but this is really important to get this patient to the next level of care. So we'd like to fix that and get that process more clear. Okay, we come to practical considerations. And again, happy to answer any questions if anybody has them, but I'll do a brief buzz through practical considerations and then we'll chat. So, as a reminder, in Washington State, Medicaid is Apple Health. Lots of people don't know that they're in Medicaid, they don't know what Apple Health is, so one thing you can do when you're talking to people, whether in your professional life or your personal life, is remind people that this is what Medicaid is in Washington State, so if you hear about Medicaid, that's what this is. It's helpful for you to be aware of, as you work in healthcare world, that Medicaid changes are scary for people. Even though they're not hitting right now, there may be a lot of churn, a lot of anxiety, a lot of people saying, should I even try to get health care? Am I worried about my ability to pay for it? We will continue to see state agencies that just don't have the resources to do the things they've been doing. DOH has taken cuts, DSH has taken cuts, OIC, the Healthcare Authority. The people who you have relied on to be a state partner with you may not be there, or they may have changed roles. We've seen a couple instances in the Department of Health where people have left who were very good at their jobs, but they were downsized, and the new people coming in were also good at their previous jobs, but they didn't, if they're coming into rural healthcare and they previously did certificate of need, that's not a one-to-one expertise swap. And we talked about immigration concerns. I think there's going to continue to be a population of folks who are wary of getting health care because of their immigration status, or they're in a mixed family, or they're otherwise concerned about the other thing that somebody pointed out to me was we may see workforce reductions in long-term care settings for people who are maybe immigrants or who have mixed status families who don't want to be anywhere near health care at this point. I mentioned concern about charity care. So charity care in Washington State is a requirement as part of your state, your license to be a hospital in the state. You have to provide free or reduced health care to anyone who meets income and family size eligibility. It applies whether you're insured or not, and it's based on, as I mentioned, family size and income. Excuse me. And the important thing here is that if somebody's eligible for charity care or may be eligible, they need to apply with the hospital, but the hospital cannot charge them or collect any money from them until they've done that screening of eligibility. So if you have a person who's a Medicaid patient who is 138% of poverty and would qualify for Medicaid, would qualify for charity care if not for their Medicaid coverage, and you need to collect a copay from them, it is unclear if you can do that. You can do both things. Can you comply with state and federal law at the same time? And we really like to comply with both state and federal law because it's really bad to break either one, but we will see what this looks like. The other thing I wanted to just flag for you is again to that point about if the federal government gives the state fewer dollars, the state has to either find dollars or cut services. Unfortunately, a lot of the Medicaid program is mandatory to some extent, but there are flexibilities that the state has chosen to do. So, example, we have pretty rich Medicaid benefits when it comes to vision, mostly dental, other things. So there may be cuts in those services, but there are also probably going to be cuts in other things, especially around long-term care for Medicaid patients. So these are just some examples of things that the state chooses to fund when it comes to healthcare that they may have to choose not to fund, either wholly or in some kind of reduction. So again, the last time we saw a big state budget hole was in the Great Recession, and at that point, most states, including Washington State, cut long-term service and supports Medicaid programs. 86% of optional medical spending supports older Medicaid patients, so just be aware that this may be coming our way. There we go. And last but not least, or two more things. Excuse me. One, I would think about internal preparations as you're thinking about the coming HR 1 implications. If you are a provider of care to Medicaid patients, can you tell if they're traditional or expansion? You can if you access Provider 1, we think, but Provider 1 access is often limited, and it takes a bit of training to figure that out. I would think about education support for enrollees. If you have current Medicaid patients, what can you do to help them understand what is coming? You don't want to say to them, worry right now, but worry for the future. Like, be prepared for these things that are coming. I would encourage you to be ready to assist patients when it comes to paperwork for re-verification, for work requirements, for exceptions. And thinking about accelerating, if you are helping people apply for Medicaid, think about how you can accelerate that process, because again, you get 30 days retroactivity for expansion populations. And this is really the last but not least. So I find this whole topic to be a lot depressing, because there's a lot of tough things that are coming our way, things that you can think about for yourself that I think about for myself. Your role is critical. You have expertise in this area. People in your family and your community may ask you questions, so I would encourage you to be educated about what's going to happen, what the facts about what's coming down. I would look at your internal processes. You cannot control what the external world does. I cannot control what the feds do or the state, but you can control your internal stuff, so really look internally and figure out what you can do with your internal world, maybe your internal personal world, but your internal professional world. As I mentioned, stay informed. You're going to be looked to as an expert. It's okay to acknowledge that it's uncertain and that it is potentially going to be hard. I like to think about it as that a worry, concern, or a problem. Worries to me are like really big, nebulous things, but problems are the thing that I have to figure out right now, and you may spend your time in the problems versus the worry. Focus on the facts and then share resources and ideas. WSHA has a work group that's going to meet on HR 1 planning. So if you're interested, please let me know. If you're a WSHA member, I'm happy to connect you with who is running that program. And that is really the end. I'm happy to answer questions. I appreciate if you've now spent 75 minutes of information and you would like to process that elsewhere, but I'm happy to answer any questions. I Beat you down. All right.
Going back to the $50 billion rural healthcare transformation fund,
Yeah.
We were briefed by our council as a part of our submission that it has to be a net new service. We can't be subsidizing current services, we can't layer it into operating expenses, yada yada, as a part of that, and especially pertinent to the east side of the state. I'm not sure if that was really determined or if you have a different perspective of what could be a part of that submission if we are, applying for it.
Yeah, that's a great question. So the way that it works is that each state applies, but hopefully each state is talking to their internal, their state folks to say, what would you like, what would be helpful. The feds have said in the SCMS FAQs say that they will not approve money to be used for rate increases, for funding infrastructure for individual facilities, which is a real bummer because there's a lot of rural hospitals that could really use infrastructure support. And they don't want to, quote unquote, bail out distressed hospitals. So that's the kind of the edges that the feds have set. I think it's within that framework a little bit of Wild West to kind of how states are putting together their proposals. And I think especially because they have to kind of commit now to what they want to do for the next 5 years, it's an interesting question about kind of what would be in state submissions. I don't know what would be the most attractive to the CMS administrator, right? Because there's the 50% that's going to be, if you were approved, you get money, and the 50% is CMS administrator discretion. So that doesn't help at all, but I confirm what you're saying if there's some limitations.
I had a quick question.
Yeah.
So I'm a healthcare provider within the city of Olympia, and there's some legislation on the ballot not specific to healthcare, but is around minimum wage, safety in workplaces, around providing panic buttons in isolated areas, and also some legislation around scheduling practices and that actually go above and beyond what's kind of currently within the state legislation piece. And so do you see this as kind of a growing trend within other municipalities within the state of Washington from your perspective, and this is a trend that we should be watching out for in other areas?
It's a great question. I think I haven't looked at Olympia's proposal, but I've heard similar. Probably yes, right? Because I think that there are, especially from our bigger cities, some real concerns about what are we, the city, able to do to really protect our workforce or make this a better, safer place to live and work and play. And I think, and this is pure speculation on my part, I have no data to back this up, and this is Zosia, not the Hospital Association. But it feels like if you're a city that says, like, I really want to do something and I want to protect people and I can't manage the federal government, I can't impact the decisions that ICE makes, I can't individually fund my hospitals, but I could maybe make workplaces safer. I think we may see more of those trends, and I think we could also see some more local taxing authority, where the local authority says, I would like to have more money to do the things that I think are important for my community, because I'm not going to get state or federal dollars.
And I think the biggest concern I have is it's not going through the rulemaking process per se, right? It's initiative that's backed by the union that's being put on the ballot, that is likely to, it's going to pass,
right.
And you can't really go through that back and forth process. And so it's more of just an FYI that it could be coming to a city near you.
I appreciate that. Yeah, sitting near you, I think it's a very good point. And I know at the state level for initiatives, right, they do, because we had the 4 or 5 this last round of election season, and at the state level they go first to the legislature to say, would you like to pass this as a law? And if the legislature does that, then if they pass out a law, they can then amend that law pretty quickly. But if the initiative is passed, the legislature is kind of hands tied for a couple of years. They can't undo or clarify anything in the law. So and it's a very interesting question about whether the cities have a similar, like the city codes are such idiosyncratic beasts. It's a very interesting question about how that happens. But I appreciate. I'm gonna look at the Olympia proposal. That's very interesting. Thank you. Questions, comments, concerns? We'll just assume concerns. Questions, comments? Okay. Well, thank you for letting me talk at and with you for this time. I really do appreciate it. I'll be around if you have any questions. I'm happy to answer questions. You have my email address. Feel free to email me. I don't always know the answer, but I can usually find somebody who can at least opine and chew it over with you. I really do appreciate it. I hope you have a good rest of your day. Thank you.